Good morning, friends. Continuing in the series, we'll start with Myasthenia Gravis. Okay, so we have been reading it since grade 7 and 8. It's a very easy topic. So what happens is it's an autoimmune disorder where antibodies are produced. Okay, where antibodies are produced against acetylcholine receptors where at the motor end plates of the myoneural junction. For example, this is the muscle and this is the nerve. So at the motor end plate there will be acetylcholine receptors against which the antibodies are produced. Now who produces these antibodies? B lymphocytes and defectively regulated T lymphocytes. In at least 65% of the patients we have thymic hyperplasia. So it means that in myasthenia gravis thymus plays an important role. Then we have clinical features. So onset is 5 to 15 to 50 years. Females are more common. Any autoimmune disease, name it myasthenia gravis, rheumatoid arthritis, everything is common in females. So autoimmune diseases are common in females. So we have remissions and relapses seen during the early course of treatment. Easy fatigability, it is associated with paresthesia of muscle. So weakness of muscle is present. Repeated contraction will worsen the weakness, and we know the reason that more the contraction, more the acetylcholine releases, more it gets depleted. Okay, then reflexes and sensations are normal. Only motor symptoms are there. Diurnal variation is present. Towards the evening, the symptoms will become worsened. Ocular muscles are most commonly affected, resulting in ptosis, diplopia. However, pupils are not involved. Okay, so we have that myasthenia gravis is of two types. First is ocular, another is generalized. Okay, so ocular means involving eye, generalized means involving the whole body. Okay, bulbar muscles. What are bulbar muscles? Muscles that are supplied by cranial nerves from brain stem. Okay, so they will cause dysphagia, nasal regurgitation and nasal voice. Now proximal group of muscles, they lead to difficulty in raising the arm above the shoulder, question stem, and problem in getting up from squatting or sitting position. If respiratory muscles are involved, this is known as myasthenia crisis and it can cause death. Investigations. So you see, we have this test. This is known as Hydrophonium Test. So this is also known as tensilon test. This is Hydrophonium. What is Hydrophonium? It is an anticholine esterase inhibitor. Okay, so we have acetylcholine esterase that will destroy this acetylcholine. So if we inhibit this acetylcholine esterase inhibitor, acetylcholine esterase by its inhibitor, the acetylcholine will survive and there will be increased concentration of acetylcholine, and this will relieve the symptom of what disease? Myasthenia gravis. So for a short duration of period, it reverses the muscle action in myasthenia. So in adults, first we give 2 mg of injection to check the tolerance, then we'll give 8 mg, and we'll see that there is drastic improvement in what signs? Diplopia, ptosis and nasal voice within 30 seconds and persists up to 1 to 2 minutes. Very short acting. Positive signs suggest it has myasthenia gravis. Okay, now if the symptoms worsen, then we can have another condition. This is known as cholinergic crisis. So it is also a differentiating test between cholinergic crisis and myasthenic crisis. What are the other tests that we can use? We can go for chest x-ray to detect thymoma, thyroid function test to rule out hyperthyroidism, anti-acetylcholine receptor antibody levels. We can go for muscle specific protein kinase antibody. These are anti-low density lipoprotein related protein 4. Electromyography and ICE test. So what is ICE test? That in this, if we place a small cube of ice over the eyelids for 2 minutes, there will be improvement of ptosis. So it indicates it's a disorder of neuromuscular transmission. Management. So it is mainly symptomatic. We give 2 drugs, neostigmine and pyridostigmine. Neostigmine is 15 mg, 1 to 2 tablets, 3 to 6 times a day. Pyridostigmine is 60 to 120 milligram 3 to 6 times a day may be used. What are the side effects of these medicines? They can cause abdominal cramps, increased salivation. Pyridostigmine is more better tolerated than neostigmine due to fewer gastric effects. Corticosteroids can be useful in induction and maintenance of remission. Okay, but in 15% patients it can worsen the myasthenic crisis. So it should be given with caution. Thymectomy is done to induce resection in people who have thymoma. Okay, then if steroids are required in a very high amount, then we cannot give them due to their disadvantages. So we give with immunosuppressive agents like azathioprine and tacrolimus. We can also give immunoglobulins against those antibodies if we are going to do a surgery or during myasthenia crisis. And if someone has ventilatory support, we give him ventilatory support and nasogastric tube for feeding. The drugs that aggravate myasthenia gravis, most important is aminoglycoside. Then we have cardiovascular drugs like lidocaine, beta blockers, calcium channel blockers, quinidine and procainamide. Okay, so the prognosis is variable. That is common if the crisis occurs in the first 2 years, 2 to 3 years. Then we talk about a very important disease that mostly shows up in the exam, that is Guillain-Barre syndrome. It is also known as acute inflammatory demyelinating polyradiculoneuropathy. Okay, so it is the commonest acute demyelinating polyneuropathy. It is presumed to be autoimmune in nature and affects any age. It usually follows an infection of a bacteria, that is Campylobacter jejuni. It is a gram-positive rod curved bacteria, but here it is written viral. I don't know why. It can also be after immunization. Exact pathogenesis is not known, but what is proposed is that GBS is monophasic immunologically mediated inflammatory disorder of peripheral nerves. So there will be inflammation of the peripheral nerves that will lead to paralysis. Okay, so there will be multifocal demyelination of the nerves that can lead to conduction block in nerves, and it forms secondary axonal degeneration. So it will follow an infection, that is Campylobacter jejuni most commonly. So anti-ganglioside antibodies are seen at least 1/3 of the GBS patients, proving our hypothesis, and they cross-react with antigens in the liposaccharide of Campylobacter jejuni, means he is the culprit. Okay, so antibodies against these gangliosides, they can be called as GM1. Okay, so it is also known as acute inflammatory demyelinating polyradiculoneuropathy. Okay, GBS. Now it is a acute disorder. Okay, it usually progresses for few days and rarely can go up to months. It is predominantly motor. It does not have sensory symptoms. Minimum sensory symptoms that you can find is distal paresthesias, okay, abnormal sensations, and mildly disturbed joint position senses. Motor paralysis is more striking and symmetrical and affects proximal muscles more than distal muscles. Okay, so they will first go from legs, then will go to arms, face, eyes. So this is an ascending paralysis. Reflexes are absent. 50% patient will have bilateral weakness of face. Okay, then we can have bulbar muscle weakness. Respiratory paralysis can occur in few, and autonomic disturbances can be there, like in few only, sudden fluctuation in BP and heart rate. If there is bladder involvement, it means it is not GBS. What are other variants of GBS? We have Miller-Fisher syndrome. Okay, it is a variant of GBS, and it is characterized by AAO, areflexia, ataxia, ophthalmoplegia, without significant limb weakness, and it is often preceded by Campylobacter jejuni. Okay, and what does Campylobacter jejuni do? It produces bloody diarrhea. Other variants, we have Aman, acute motor axonal neuropathy. Okay, and Ansan, acute motor and sensory axonal neuropathy. Okay. So we come to the course. The muscle weakness progresses over 1 to 3 weeks. Then there is a plateau for next several days to weeks, and before gradually it recovers. Okay, on recovery, nearly 15% patients have no deficits or minor deficits. Okay, then investigation will see that CSF becomes abnormal after 1 week of illness. It has raised protein more than 45 milligram per dl and normal sugar. Okay, this is known as albuminocytological dissociations. Okay, albumino means protein and cytological means the cell count. Okay, it increases, it remains normal, but if there had been infection, then the cytological dissociation won't have been there. The cells would have gone up, but it is never above that. So it is albuminocytological dissociation. This is important. Nerve conduction velocity show slowing of velocity and conduction block. This is demyelinating pattern. Acute intermittent porphyria, post-diphtheric neuritis, drug-induced acute polyneuropathies should be the DDs. Then should be ruled out. Then we have management. So we'll manage the airway, breathing, circulation. ABC will monitor the blood pressure, cardiac activity, and autonomic instability if the patient has so. Steroids are not of any use. We can use plasmapheresis, plasma replacement exchange, and intravenous immunoglobulin can be used. This is 0.4 gram per kg per day for 5 days or 2 gram per day for 2 days, and they can show accelerated recovery, otherwise it does not have any treatment. Now we come to multiple sclerosis, yet another important topic. So it is also an autoimmune disease, okay, of white matter. Again, myelin. It is interaction of genetic and environmental factors, example vitamin D deficiency and smoking. It affects young and middle-aged person. So what happens is there is chronic inflammation and demyelination and axonal loss in many cases, and they will remit, exacerbate with clinical signs and symptoms. So it shows a classification. First, there is RRMS, relapsing remitting multiple sclerosis. 85% of cases are this only. So what will happen? The patient will stabilize over several days, okay, and then improve. Then spontaneously or is exposed to corticosteroids within weeks, he will improve. Then patient will be stable between these periods, and it will again relapse, then remit, and the disability develops over time with stepwise accumulation of deficits. First his eyes be gone, then his nose, then his mouth, means the deficits are being collected every time. So you can see that exacerbation, he is stable, remission, exacerbation, remission, and you can see the graph is going like this. It is accumulating. Okay, then we have Ppms. What is Ppms? It is seen in 10% of cases where there is gradual progression of disability without any relapses. Okay, superimposed relapses. So there will be no relapses. You can see it is going upwards and it is not getting stable. It is not going downwards in any way. It is never going downwards. So that it is primary progressive multiple sclerosis. Then we have secondary progressive multiple sclerosis. It is gradual progression of disability with or without any superimposed relapses following initial RRMS pattern. First it will follow this pattern. Now this will come to this pattern. So this is secondary progressive multiple sclerosis. So you can see first it is showing RRMS pattern, then it is showing Ppms pattern. Then we have PRMS pattern. So it is primarily progressive, but subsequent attacks at some point afterwards onset. So you can see it is progressively relapsing. It is increasing, but it is also so there will be gradual progression of disability from release, and there will be relapses. So first it will increase, it will continue to increase, and then we'll get relapses. So here first we'll be able to get relapses, now it is only increasing. Here it increases and then we get relapses. So most common is RRMS, that is relapsing remitting multiple sclerosis. Okay, all type of MS are further classified as either active or inactive, okay, based prior 12 months. Okay, then we have clinical features. Sensory, the upper motor neuron weakness of the muscle. So what does upper motor neuron do? The very brisk tendon reflexes, Babinski sign will be positive, loss of abdominal superficial reflexes will be lost, there will be wasting of muscles of hand, and spasticity will be there in advanced cases. Then in sensory, there will be tingling and numbness. Objective sensory loss will be there, particularly posterior column, which is responsible for proprioception and vibration. Cerebellum symptoms are common, ataxia, dysdadokinesia. Uthoff's phenomenon is that whenever the person is exposed to heat, then it will worsen the symptoms. Diagnosis, 10 to 15 years of onset. Okay, acute episode must last for at least 24 hours in absence of fever and metabolic derangement. Otherwise, it will mean that it is due to fever that these symptoms are coming. More than one episode of cranial nerve functioning within 30 days of event. Involvement of more than one areas of CSF. Okay, so acute attack, what it means? That more than 12 hours, no fever, metabolic derangement. Okay, within 30 days of event, again there should be another episode, and it should involve more than one area of the brain. Investigation, we can do electrophoresis of CSF. Electrophoresis, the spelling is wrong, I've typed it wrong. Phoresis, showing oligoclonal bands. What are these antibodies? MRI is very sensitive for detecting lesions. They are typically periventricular in origin, around the ventricles. It shows lesion dispersed both in time, meaning there can be old lesions and new lesions, different locations in the brain. Okay, in patient with optic neuritis, gadolinium enhanced T1 sequences reveal optic nerve enhancement in most patients. If the optic nerve is involved, and optic nerve enhancement can be also seen in most patients. Treatment. Okay, acute exacerbation, will give methylprednisolone 1 gram IV daily for 3 days. This is the standard therapy to hasten the recovery, but it does not alter the extent of recovery. It will recover how much it is intended to. Disease modifying drugs, we can have interferon beta 1B or interferon beta 1A. We can use these two drugs. Symptomatic treatment, for spasticity we can give baclofen. For pain we can give carbamazepine. It is a neuropathic pain. For fatigue we will give modafinil. And for impaired ambulation we will give dalfampyridine. Thank you.